This video is part of our Virtual Technology Showcase series. This is one of a two-part series in our Emergency Medical Services and Telehealth Video Toolkit. We recommend watching part 2 after this video as it contains a helpful Q&A recording from our live 2022 event. That and other resources are linked below. Enjoy the video.
Hello, everyone. I'm Christina Higa. I'm from the Pacific Basin Telehealth Resource Center, and this session is focused on mobile technology, infrastructure, and EMS. However, we'd like to start with thinking about the role of telehealth in improving patient care. And so I would like to introduce our first video. It's of Dr. Matthew Koenig of Hawaii. He's a neurointensivist. And he's also the telemedicine director for Queens Medical Center, which is one of our largest health centers in Hawaii. Dr. Koenig is also a true telehealth champion. He not only expanded our telestroke network, but he also was a very strong advocate for creating enabling telehealth policies and telehealth partnerships in Hawaii. And all of his work in this area is with the main objective of improving access to care and health equity. In this video, we're about to show Dr. Koenig will explain the importance of time and stroke and also the potential benefits of telehealth and stroke care.
Hi, I'm Dr. Matthew Koenig. I'm a stroke neurologist and neurointensivist at the Queens Medical Center, and I'm also the medical director of telehealth for Queens Health Systems. The treatment of stroke is really very time dependent, and for two reasons. One is that the longer neurons in the brain do not receive blood flow, the more permanent damage sets in, even if that blood flow is eventually restored. The other factor that people don't consider as much is that the clot that's blocking blood flow to the brain actually hardens over time. And so the effectiveness of medications and therapies to actually remove that clot or break that clot is reduced as time goes by and the clot hardens. The story of stroke treatment and the story of telemedicine are really combined. They're really the same story in a lot of ways. And that's because in the late 1990s, when TPA, the clot buster medication, was first approved by the FDA, that's a time when technology was advancing to allow stroke specialists to reach beyond traditional borders and treat patients with strokes in smaller communities and smaller hospitals. Telemedicine is a really important tool for neurologists at stroke centers to reach beyond their walls into smaller communities and smaller hospitals that don't have a neurologist on call, and lend the stroke expertise that's necessary to make safe and timely decisions for patients who are having strokes in those areas who otherwise might not have access to a professional. The link between telemedicine and stroke really continues now as we grow beyond the traditional hub and spoke telestroke models into the pre-hospital setting, where neurologists and other stroke experts are able to see patients in the ambulance before hospital arrival, identify stroke in the field, and make sure that patients are taken to an appropriate hospital that can treat that patient for stroke. Treatment of stroke patients is sometimes not straightforward, and an expert opinion is needed from a stroke neurologist. It's important that we're able to look patients in the eye so when they call 911, we can tell them, wherever you're taken for treatment of that stroke, you're going to be seen by an expert with knowledge of stroke treatment, who can examine you and help make decisions on how best to treat that stroke. And telemedicine enables that neurologist to reach beyond the walls of their hospital into smaller communities that otherwise might not have access to that kind of expertise.
Elizabeth Krupinski from the Southwest Telehealth Resource Center, and we've had an emergency medical services program as part of what's going on at the University of Arizona Health Sciences Center. And I'm going to show you a video that's been created by Dan Dirksen, and he's our Associate Vice President for Health Equity Outreach and Interprofessional Activities. He's also a professor of public health with joint appointments in our College of Medicine and the College of Nursing. He's also the director of the Arizona Center for Rural Health, and that's where he gets involved in sort of this EMS services activities. He's also, since 2019, been the senior advisor and PI on the Arizona AHEC program. He does a lot of activities from informing legislative, regulatory, and program policies to improve health equity, to increasing insurance coverage, reducing the uninsured, just anything and everything that has to do with rural health practice, getting stuff out there. And as this video is going to highlight, stroke is very important, but there's a lot of other aspects that are integral to EMS services. And some of them are, more for trauma type activities. And being in the Southwest in a border area, a lot of open roads, long stretches of highway, there's a lot of accidents and an increasing need for EMS services throughout the state. And some of our unique populations, Native Americans, Hispanic populations that live in some of these very rural areas, really are benefiting from our EMS services.
Certainly seen during this intractable COVID pandemic, the value of telehealth technology. In Arizona, we've seen that this is very useful for emergency medical services out in the field in rural areas to connect directly with emergency medicine physicians so that they can decide whether something can be handled locally or needs transport. We've seen during the big surges like what we're experiencing right now, where every emergency department and every hospital has exceeded or is at capacity, the importance of being able to communicate directly with ambulances and EMS personnel to make sure that individuals who need higher levels of treatment can get there. Another way that the telehealth technology is assisted for some time now, the major payers, whether those are public payers like Medicare and Medicaid, or private payers through private health insurance, employer-sponsored insurance, now pay for telehealth services. So for individuals who are reluctant to go in to a busy clinic or emergency department for fear of being exposed to individuals who have COVID or other transmissible diseases, can get their care online, and that's covered by their third-party payer. So that's been a huge, important change that's happened over the last year and a half or so that we've been dealing with the pandemic. But it's also helped us manage those individuals who have other problems where emergency departments are full or the hospitals at capacity and have emergency situations where they need assistance. And telehealth has been able to help with the triage of that and appropriate transfer for patients who need tertiary care. Well, we've had some challenges for some time with certain parts of rural areas of the state where individuals, say in the northeastern part of the state, say on the Navajo reservation, where the facilities may quickly exceed or saturate their capacity and need assistance. So we've seen the ability of telehealth to help manage either the transfer of those patients or the management of those patients on site in a rural or critical access hospital, Indian Health Service site, or a tribal operated clinic or hospital. And so the telehealth technology has really expanded the reach. We've seen that really does expand in the access to care for individuals who may be along the US-Mexico border or in our federally recognized tribal entities.
Hello, everyone. My name is Thomas Corey, and along with Brian, I'm an engineer at the University of Virginia Center for Telehealth. In a moment, we are going to show you a few short videos simulating transport of a stroke patient at different levels of cellular bandwidth. As you watch, please note the range in video quality, and afterward, there's going to be a poll where I'd like you to assess which video you consider best for a physician encounter.
Thanks. Huckleberry. baseball player. Thanks, Huckleberry, baseball player. Thanks, Huckleberry, baseball player. Thanks, Huckleberry, baseball player.
Yeah, we see that overwhelmingly people are voting for video A. Video A having that mix of clarity on it. The other two kind of even split, but video A definitely a winner here. So first off here, we're just going to give you a little still frame. When you look at the video side by side, it is easier to see those differences in clarity. And you can also see that in the 5G video, you see some of the reality of doing the encounter on the back of a moving vehicle as the shadow moves across the patient's face. As we talk about telehealth over mobile technology, it is worth having a bit of a foundation in how cellular towers operate and the limits that can impact the quality of the video. Typically, when we're talking about modern cellular, we think in terms of 3G, 4G, and 5G. These designations refer not only to the generations in tech, but also the different bands of frequencies on the electromagnetic spectrum. While you might see theoretical maximums that are much higher based on perfect lab conditions, the average speed you'll see are around 1 to 3 megabits per second using 3G, about 5 to 8 on 4G, and it jumps all the way up to 30 to 50 on the latest and greatest, which is 5G. One limiting factor on this falls back to the connection on the tower. The cellular radio that's built onto the tower still relies on a wired connection back to the central office. So a tower with a 3G radio might just have a pair of bonded DS1s, digital signal 1 copper lines supplying the data. Each of those has a bandwidth possible about 1.5 megabits per second. So at the upper end average of 3 megs for a 3G tower, you can only support one call at a time at that full capacity. At 2 calls, you cut that bandwidth down to half. At 4, you take it down to a quarter, and at that point, you're already brushing the lower limit of what's necessary for a telehealth call. If a fifth person opens up YouTube and starts watching a cat video, the tower's capacity gets split further, and your call might fail. Now, while more and more towers are switching out to higher capacity copper using a DS3 or to fiber optics referenced on the slide here as optical carriers 1 and 3, these lines are expensive to establish, to maintain, and to transmit. The further you go out into rural communities, the more likely the towers are going to have an insufficient capacity. Add to that, towers with 3G and 4G are limited to only about a range of 1 to 2 miles around them for reliable data transmission, while 5G has greatly reduced that capacity down to a working range of about a quarter to a half a mile. When in transport, that means that your call will frequently hop from tower to tower, and that's potentially going to introduce variations in the quality. So what can we do to mitigate this? For one, you can install signal boosters with external antennas in the ambulance. They're going to increase the strength of the cellular radio that is there in the ambulance for both transmission and receiving from those towers. This allows for a higher level of signal stability over a greater distance and will also assist in that handoff moving from one tower to another. Secondly, going back to that limited capacity, the tower to support multiple calls at one time, carriers such as Verizon and AT&T have implemented what's called quality of service for first responders. This gives their registered cellular devices priority, so instead of splitting the tower capacity equally to each person on a call or on a data connection, the first responders are given priority and given a bigger piece of that pie to maintain the quality of their data and of their video. To speak further on experience using telehealth in conjunction with EMS, I'll hand you over to Brian Ganell. So Brian, what have we learned?
All right, some of the things that you have to consider when mounting equipment in the back of an ambulance. One of the first things that we come to is the cost of the equipment, whether you use mobile devices or endpoints. When we first started this work, and one of the programs that I've worked on is called iTreat, and it was doing pre-hospital stroke assessment specifically. When they first approached me around the specifications on what equipment to use, I basically said we needed about $50,000 to build out a singular ambulance with a solid system that would be able to provide this mobile support. And I was told that I was crazy. There's no way we could build that out across a whole fleet of ambulances. So then I asked for 20, and that was still considerably high. And so with the first iteration of iTreat, we actually used tablets iPads off the shelves and a lot of off the shelf devices at a very low cost. That allowed us to really build this out in a lot of different ambulance agencies around us. And that's one of the unique things about UVA specifically is we have about 8 different providers that bring patients to us. And so we really had to be fairly nimble with the technology to be able to build this out. One of the other hurdles that we came to very quickly that nobody really anticipated was going to be a challenge was the mounting of the equipment in the back of the ambulance. When we started again, we were using iPads, mobile devices. We used suction cup mounts to be able to put those on the ceiling of the ambulance because we didn't want the providers to have to hold things in their hands. And that worked pretty well for the first iteration, but there was always a challenge of having to pull the equipment out when we needed it and to put it in place to use it. If you look at the picture to the right on the slide there, that is a Cisco branded endpoint that we have now mounted in the back of ambulances. We're using Velcro and zip ties right now as we're not allowed to permanently mount in the ambulances that we're working with. But we do see this in the future as mounting these permanently and not having this sort of mobile Velcroed solution in place. One of the other things to think about when you're mounting the equipment or what you're going to use is the camera type and position. We're using pan tilt zoom cameras now so that the physicians dialing in can actually move the camera around and they can see what they need to see. So if they need to look at the eye movement or they need to look at the legs, they're able to control those cameras by themselves. But it's something you have to think about where and what you're going to put in the back of the ambulance, and then whether you're going to be directing the EMT to move that device around or if they're going to be able to do this completely hands-free. We really try to go with the model that the EMT has to do very little once we start the system and get the call established. They just need to stand back and listen and be there just in case there's something some questions they need to answer. One of the other things that we found to be very important is whether you use standards-based or proprietary equipment. If you're in the telemedicine industry or you've been in it very long, you know that there's a few different types of platforms: Zoom, WebEx, Cisco Call Manager, H323 calling, and a lot of different standards out there. Trying to find a singular system that all the different providers use is a challenge. And that's why we've always really focused on standards-based SIP and H323 calling, is that gives us a pretty wide array of people that we can call. But making sure you have those systems established at the facilities that you're going to be referring to, and then have providers available there to answer with those systems is key. And that's been a big challenge to make sure that we have that with all the different providers and systems that we work with. Some of the other things to keep in mind in the back of the ambulance is audio is always a challenge. You have to deal with a lot of road noise and air handlers. And sometimes the simplest thing to do is just to turn off the air handlers, the HVAC system. They bring a lot of air noise, but those are the simple things that you have to think about to help improve the situation. A lot of the software and applications that we use now does have noise filtering. This does present some unique challenges in the fact that it could actually cut some of the audio out that may be important for the physician to hear. You may not be able to hear some of the things, some of the edges of the voice. And if you start to use any sort of peripheral devices, using noise filtering could potentially impact that. So you have to be very careful with some of those things, but we do see that technology getting better. Patient audio, we've actually had both external speakers and headphones deployed in the back of the ambulance. A challenge with the headphones is the EMT may not be able to hear what's happening between the physician and the patient. External speakers require other things that have to be hooked up in the back of the ambulance and powered. So just things to consider as you're doing this. Some of the other barriers that we've come across, and to be honest, the bigger barriers in the whole situation is the people factor at a lot of the different EMT agencies that we work with. There's a lot of turnover or people that cover during different shifts. And so making sure those people are properly trained, the time of the transport, so how long they're going to be in the back of the ambulance on the way to the hospital, or if they're going to stop at, say, like a touchdown point. We're in a pretty rural environment, and we have some places that might do helicopter flights back to the hospital, and the potential for the EMTs to stop and have a conversation with a physician at one of those stops before they take off in a helicopter could be pretty powerful, cutting off time when they get to the ambulance. As we've heard too, mobile bandwidth and coverage area is always a big challenge. So you have to really do a lot of testing and to understand what your mobile environment looks like. And then having those available providers to be on the other end of the calls. That really is one of our last challenges, is making sure that we have the physicians and the workflows in place to be able to serve these patients wherever we go.